how you hold your polishing strip is very important. What people tend to do is that they wrap the polishing strip around the tooth and then start cleaning like that.
Like a wrap it around a C.
Correct. What you should be doing is what people don't understand. Are like, but Teflon's so easy. You just wrap it around the tooth. Yes, but you have to wrap it around the whole tooth. And then you have to make sure that it doesn't fly away. So this is quite different from, using Teflon when you're, cementing a veneer. That's easy peasy lemon squeezy. Using it in these kind of cases is very hard. On that note, what is so nice about the alternating matrix technique is that you only need the Teflon for the second half of the procedure. What you then have to do is that you take a fine instrument, like for example an IPC, and you adapt it a little bit in the interproximal so it doesn't bunch there.
Injection molding has been an absolutely brilliant thing in dentistry. It's really boomed in the last 5 years. Now, previously we had a really great episode with Dr. Kostas Karagianopoulos, well worth checking out. We have like a really awesome infographic you can download for that one. And it's a great beginner's guide to injection molding. But today it's an honor to have Dr. Sandra Hulac. It's her return on this podcast. We love Sandra. We love her direct style of communication. And I tasked her to tell us about how to minimize the cleanup. Hello, Protrusive. I'm Jazz Galati, and as much as we do love injection molding, it can be extremely messy. Like, you spend all this time cleaning the teeth, you get the stent on, you inject, you're paying so much attention. By the time you take the stent off, you're already tired. You have the occlusion to think about, you have the polishing to think about, except the whole polishing and cleaning up can really take a long time. Until now. Sandra gives all the secrets away. Essentially, it's just a few things to remember. The design phase, the stent phase, the insertion sequence, and the easy peasy cleanup protocol. And Sandra does a wonderful job of breaking all this down. So whether you've got your first case of injection molding coming up and you want to start with your best foot forward and minimize that mess in the first place, or maybe you're a seasoned expert and you're still getting too much excess and too much mess, this episode is going to be really impactful for you. Now, every PDP episode, I give you a protrusive dental pearl. The pearl today is the infographic for this episode. Team Protrusive carefully collected the visuals and a concise summary of the exact steps to follow to minimize the mess. If you're on Protrusive guidance watching this, scroll down, you can download it straight away. But if you're on YouTube, Spotify, etc., just head over to protrusive.co.uk/no mess, all one word. That's /no mess, and I'll email you our most excellent infographic. That'll be a wonderful aid memoir when you do your case, whether it's the design stage or the cleanup stage. This will be an excellent visual summary of this episode. Let's now check out the main interview, and I'll catch you in the outro. Dr. Sandra Hulac, welcome back yet again to the Protrusive Dental Podcast. So great to have you. You've got your Brittany mic, as I like to call it, on again. You've just probably finished a hard day at a clinic, and I'm familiar to this scene now. I've seen some of like previous webinars where you're usually, this is like you're in the zone for like a presentation mode. So nice to have you. Recently, you were just at BACD in Manchester teaching on one of your favorite topics. And so tell us about what you've been up to since we last spoke, and how was the BACD?
So since we last spoke, I had a couple of courses in Singapore about injection molding as well. One of them was 3 days and included a full day lecture, which is similar course to what I'm going to be doing at the end of the month in Sydney. And then I had another one, 2-day course in Singapore, which was just a repeat of the workshop because the workshop sold out fairly quickly. So that was really, really good. And then I've been doing some courses in Hong Kong, but it's not very popular in Hong Kong. It's a bit of a problem to get stuff filled here now. And I had the BACD that was absolutely fantastic. Really enjoyed that. Such an enthusiastic public. Oh, I also was in India for a couple of days. I did a workshop there. And end of the month, I'm going to Australia. Now I'm talking to you in the hope that we can do something. Yes.
Next year, we've got a really cool thing planned whereby I think we should just talk about it, because what we classically on, and the reason I'm very excited to work with you, Sandra, is classically on all sorts of courses, whether it be occlusion or injection molding, we use typodonts. Now, you can't learn occlusion on typodonts, and whilst you can learn some nuances of the technique of injection molding on typodonts, they are not representative of the population that you treat. And so can you tell us about some of the cool stuff you're innovating in the education in this space?
So what I'm actually doing with the course that I'm running in Australia and the one that we are going to do next year, well, sponsored by GC, thank you very much. We're using typodonts upper and lower that are actually the typodonts made from a real patient of mine that I treated with a full mouth rehabilitation. So it's much more close to the real the real thing. And then they're going to be mounted. And so then we can see and try our hand on a little bit of equilibration, because the one thing people do these kind of things first, whatever you go in, and when you do your first full mouth rehabs and you have this, what do you think is centric, and it's centric mounted, and then you put your patient in provisionals and they bite together and nothing fits and you start to completely panic. So I need to let you know this is completely normal. Then how you deal with this, how do you go about equilibration like this, and just how do you let nature take its course as well and let the system actually adapt, and what you shouldn't be so scared of, particularly when it comes to occlusion. Having said this, so I've got through like 5 different stages with the development of the typodonts. And so far, I have to say, if you manage to do it on these typodonts, the mouth is going to be a doddle because it's really difficult on these typodonts. Yeah. But I'm super excited about working
It's
with
just
those.
a representation of a real case. So when we do our occlusion courses, we have, again, mounted models, real patients. So we also treat 2 patients on mounted models that are actual patients that me and Mahmood treat in real life. And I love that you're doing this in a very innovative way to get these very bespoke. Look, it's not cheap with these typodonts, but it's so worth it to give this experience. And kudos to you for being so persistent in getting it done.
Yeah. So, and it's one of the things that is going to be good for the participants, that at the end of the course, they can actually take these typodonts home because they're useless to us. So they're not typodonts where you can take teeth out, okay? If you wanted to go and develop that, oh my God, that'd be like, I don't know, 50, 60, 70,000 US dollars to get a typodont like that going. But so the typodonts we're having, they're still quite pricey. We talked about this, but at the end of the course, they're kind of useless to us. So take them home, take the matrices home, drill it off again, do it again, and so on and so forth. So
that's amazing. And the other idea I've had is, because obviously you teach in America with Kois, and you're an instructor, and so much we can learn there. I really want every delegate to be able to have a Kois appliance on themselves. So when they come to fit in their first one, so we're working behind the scenes with labs to work that out. So many exciting things. But today I really want to focus on one really niche and detailed topic, which actually everyone who's ever done injection molding or pressure molding of any sort has always noticed, especially the first few cases, the monstrous amount of mess, the carnage at the gingiva, okay? The thriller in Manila. Now, you know what I mean? There's so much, and you're already knackered, and now you have to induce so much plastic mess in terms of cleaning. So we want to dedicate this piece of content in terms of really giving valuable tips to every dentist on how to make less mess.
Yes. And I certainly can give you all the tips for that, because I've done so much injection molding, and it's always 2 problems. One is design. And that your lab has no fucking idea what you're actually doing. Okay. No, because they always think this is going to be a prep case. That is, and we're talking about that. Okay, so this is why you get a design that's completely unsuitable for injection molding. And the second thing is the matrix fabrication. If you go cheap on the matrices, which you cannot. This has to be done in a very specific way. This is why the matrices for the course that we are doing will be pre-made at great cost, because they're all laboratory made. But this is how you have to do it, because otherwise you're going to have a huge mess, particularly if you're doing these more evolved cases. And I understand that people say, no, you can do that in the course, just use a tray, and we just put it on the model and it's all fine. Yeah, you can do that if you're doing 6 veneers, but you can't do that if you have a full mouth where you're doing full occlusal coverage and all this kind of things. Now, you need to have a matrix that fits.
And that makes total sense.
And obviously also using the alternating matrix technique, which, is pretty much standard these days. But it wasn't when I started. So when I started, it was still it was 2018. Douglas Terry had come out with the book, Restoring with Flowables, where he had a whole chapter about this method, which I read. And I'm like, that's really cool. Let's try this. But this was still one tooth after the other, which, was a lot of cleaning up. However, I think in my first case that I did, I was super, super lucky. So I wasn't deterred, because I actually took off existing shitty porcelain veneers and made them into injection molding veneers. So to that extent, I told my lab just, with the design, plus this was still a VEX design. We didn't do that digitally, and that's a big There's a lot of problems with digital, but particularly when it comes with exocad and what the lab does with exocad. But so this was still a traditional wax up, and so they didn't have to really, they just had to clean this up a little bit. So I ended up with a design once I took the old veneers off that was, that's why it worked for me immediately and I didn't have this absolute nightmare. Okay. So I had my confidence. And then, the longer I did it, the more I then came across the same problems that everybody else is coming across, which is, the ginormous mess. And then you figure out why it's happening. So, yeah.
And then over the years, have you found that your mess is less and less because you're utilizing the techniques we'll talk about today, so that it's become less of a stressful thing and more of a manageable task?
Yes, definitely. So I've totally refined how they have to make the matrices. This includes the use of a pressure pot, by the way. This is essential. Okay. Also the use of a spacer tray, and we can show pictures about that later on if you want to do that.
Yep.
The other thing is the design. Tell them what you want. You have to have really, really strict design prescriptions. And I'm going to run this down now because, as I say, we are not guarding any secrets here. So the problem is, because these days this is mostly done digitally, right? You send the lab, you scan, and they're going to go and you say like, okay, you send them your centric mounting. You say, okay, now I want teeth this long and now go. And what they do, they take something out of the exocad library and they just stretch it over the tooth. And because that's super easy. Okay. And then you also have, these auto smooth or global smooth kind of tools. So there are a couple of things that are happening. Number one, they're extending things quite often in surfaces where you don't even want it. Okay. Because they take the whole tooth and say, you have a very broken down upper molar or a couple of upper molars, but you don't want to cover the lingual surface. If you don't tell them that, they're going to do that because they're thinking, oh, she has to prep this for a crown, so let's just put the whole frigging tooth on, because then they don't have the trimming to do, which is quite time consuming for them. That's number one. Secondly, what they love doing is to go with the design into the interproximal. Because again, that's something exocad really likes doing because it's so massively worried about endocuts. So it likes to add volume everywhere. And it also does these things where it like auto smoothes the interproximal embrasures. So you have a shitload of material going in there, which means a shitload of cleanup. So what you want to tell the lab, okay, apart from the fact, do not extend the design anywhere on the lingual or palatal or even on the buccal unless I tell you so, because you might not want to have, I always like with my injectable cases to cover the buccal surfaces a little bit, particularly on the top because it looks nicer. Okay. But this is something you have to decide. Okay.
Like a veneer lay, basically. So
correct.
Yeah, topping with a buccal extension. Yeah.
Correct. Because I think from 1.5 to 2.5 or 1.6 to 2.6, particularly, patients also want to have nicer teeth. Okay, this is transitional, but you still want it to look nice. So if you draw the composite over the surfaces on these posterior teeth, over the buccal surfaces, it looks nice. Most people can always do with a little bit of widening of the buccal corridor.
But Sandra, the distinction here is that what you're doing is purposeful and prescriptive rather than doing like full crown design everywhere, covering all the surfaces. Is the point. You're being prescriptive. It's taking what we know from hand waxing and being purposeful with the hand waxing into the digital world.
Correct. And the thing is, what you have to tell them that, and this is another thing, because most patients, they want to have, or if you have diastemas, you obviously have to kind of, extend over the line angle. But if you can get away with to make your interproximal cleanup a lot easier and your patient doesn't have gaps, your patient doesn't look for a huge color improvement, then by all means tell the lab to not extend the design past the line angles. Whoop-de-doo, no more cleanup. So easy. Okay.
And just to explain to the very junior colleagues who are just new to this space, if you don't extend into those areas, then the matrix has a hard stop on tooth that really minimizes how much excess can escape there. And it's all about strategically guiding the lab or where you want these areas. And once they get it, they get it. But if they're not used to doing that, like you said, they just cover everywhere, which just creates the enormous mess.
Which does cause the enormous mess. Another thing you have to make sure, because again, what the lab loves doing is, add on a lot of volume. So that hasn't got so much to do with, the mess, but this has much to do with how it looks afterwards. So what you should be going for is about a 0.7 to a 0.1 in the mid buccal maximum, okay? But also not below a 0.5. So otherwise you're going to have too much show through of the other tooth. And that, I mean, obviously then going towards the cervical thins out and thins out and thins out. And again, ideally, I want them to stop about, 0.5, 0.3 short of the gingiva, if possible, if the patient is not looking for a huge color change. Because again, that makes my life a lot easier, okay? Now, another thing that will prevent the mess, obviously, is the alternating matrix technique with matrices that are made in the lab according to instructions on the models that we have, gotten from the print that we have told the lab how to do.
So yeah, Sandra, tell us, just summarize then, what are the classic design makes that labs are making?
So the classic designs is that they either make the additions too thick or too thin. So this is why also you have to ask them when they're done with the design that they actually send you screenshots of the design with measurements that you can make sure they have done the appropriate thickness. Okay, so as I say, 0.7 to 1.0 on the facial. And if you add length, then ideally at least a millimeter, because you're going to have a lot less chipping. But, that is obviously depending on the case. Another thing that you have to ask them not to do is, unnecessarily extend into the interproximal or even go over palatal or lingual surfaces where it's not required. Okay, because it's going
obviously,
to
if you've got worn platal surfaces, erosive wear,
then,
you need to by design.
Then you have to do that, but they like to do that everywhere because it's so much easier for them in the exocad. Okay,
but to have a cervical stop where you don't extend the composite into is, again, go back to the same point you mentioned earlier, to allow the matrix to touch enamel.
Actually, correct. But also there is another thing you want to do when you're actually then doing the injection molding. Press your finger against the matrix on the buccal surface. So
it's a bit like when you're making a temporary crown, right? You got your silicone, and because it's got a degree of flex in it, you just press it a bit just to make sure it's nice and snug against the tooth. It's the same concept, isn't it?
Correct. You're pressing the finger against the buccal surface there while you're injecting.
Yeah, and while you're curing as well, like just
while
keeps
you're curing
it stable.
as well. Keeps it stable. Also avoids that you have too much flash on these.
Makes sense. Because what that's doing, actually, if you think about it, the physics of that is actually pressing against the bits where the wax up didn't cover, creating a seal at the enamel on the tooth so that it actually really minimizes the excess. That makes sense.
Correct. But, there is a fine line between pressing too much and pressing not enough. So that is also something that comes with experience, because if you press too hard, you're going to have too much distortion.
Tell us more about the every other tooth technique, Sandra, because it's something that, so luckily, when I started injection molding, that's the only technique I never knew about. So every time I do it, I always go that way. People say it's more expensive and stuff, but the amount of reduction in cleaning that it gives in the time you save, for me, it's worth it. Would you agree with that?
Absolutely. I mean, yes, you're paying for two matrices, but the amount of cleanup time you have is now minimal. So the idea is basically that you get a full design of what you want to achieve. And then once that is done, and you have approved it after you checked it, you ask your technician to take off every second tooth back to its original shape. Okay, then they either do this, conventionally or as a wax up. Okay, and based on that, you're going to have then two models printed. And on these models, they will make those two alternating matrices. When you then go with these into the mouth, okay, so these are alternating matrices. When you then go with those into the mouth, what you find is that, that basically you can do literally 5. So in a case like say you have a 10 veneer case, okay, just a veneering case, or case that has like 10 upper teeth, then you do 5 in one round, and then you'll have very minimal cleanup, and you do 5 in the next round. Whereas, so you actually put the matrix only in twice, whereas beforehand you had to basically do one tooth after the other. And every time wrap the adjacent teeth with Teflon, which is a frigging pain in the ass, because Teflon is a pain in the ass material. I absolutely hate it. No, I mean, I love Teflon, but in this specific thing, what people don't understand are like, but Teflon's so easy. You just wrap it around the tooth. Yes, but you have to wrap it around the whole tooth. Okay. And then you have to make sure that it doesn't fly away. So this is quite different from, using Teflon when you're, cementing a veneer. That's easy peasy lemon squeezy. Using it in these kind of cases is very hard. On that note, what is so nice about the alternating matrix technique is that you only need the Teflon for the second half of the procedure, because for the first half of the procedure, it's perfectly okay to just isolate the teeth during etching and bonding with, for example, up matrix bands or Haw bands, which is my preferred ways, because still, even if you have a little run over onto the adjacent teeth, you will still have a very easy cleanup. Okay.
Because it's not etched, it's not bonded, it can come away with the number 12.
Correct. It comes away with the number 12. There's absolutely no big problem. Whereas, and with a seri saw, which by the way is a pretty essential part of the procedure, I find. So if you want to start doing this procedure a lot, get yourself a seri saw. Anyway, seri saws should be part of everybody's instrumentarium.
I would not practice without these at all.
Absolutely.
Like for daily restorative use, you can't be doing composite without having something like this. It just makes it so easy. Just go in and yeah.
I mean, even just for posterior composite, anterior composite, for seats to get excess resin cement out of the interproximal surfaces. Yes, they're pricey, but they are.
But they last forever. The strips obviously can you change them over. If as long as looked after, the handle lasts forever.
No, the handle lasts forever, and the handle is the expensive thing.
Exactly.
So ask me how I know, because I just had to buy some for the course, so I had to go on Taobao. So these are clearly not suitable for intraoral use, and let me tell you, the handles are crap. So with the seri saw and the 12 blades and maybe a scaler, it's very easy to clean off any excess that you might have had in the first round.
So let's summarize this. We've got a good design protocols for our lab, which we might touch on again. Then you have the every other tooth model. And then with the every other tooth model, the first stent you use, you don't need PTFE, which makes a lot of sense. And then you can, as long as you're really important, like the Haw matrix that you use, some sort of metal band to really make sure you don't get any air abrasion, you don't get any etch, you don't get any bond. And that really makes the cleanup really easy. And you get great access for the interproximals to polish. Do you like Epitex? What do you like to use interproximally?
Just fine metal strips. Epitex sometimes doesn't cut it because you still have a little bit too much stickiness in this area. It's very, very fine, super fine yellow or white metal strips. I like them a little stiffer. But again, if you have the design that doesn't really go past the line angle, then you don't have to worry about that at all. You won't have hardly anything there. But as I say, in some cases, you where there is excessive breakdown and diastemas and color change required, then you obviously need to, unfortunately.
So large volume color changes and diastemas.
Correct.
The mess is kind of a given, but the techniques we're discussing, especially with the design and the stages of every other tooth, will minimize it. But here's an interesting question. When you've done your every other tooth and you take off the stent and it's a much easier cleanup because of the fact that you did the every other stent, at this stage, do you think there's a merit in using the glycerin at this stage and curing it all on the glycerin before you reintroduce the second matrix? Because it might make it the next composite stick less?
Well, here's the thing though, because theoretically, at least, you already have the air inhibited because the whole thing is cured under the matrix.
True.
But to be perfectly honest, particularly in courses, I find this not to be the case quite often. Which is obviously in the course you can actually not fuff around now with glycerin and rinse it all off. But in the mouth, I have found it's fully set always. So, but it might even be nicer doing that. I mean, why not?
Okay.
I will try that next time. Good tip.
Good. I was just thinking, could that work? But then when you reintroduce, when you've cleaned up that part, and now you got for the second stent, and you got obviously the holes and the correct teeth. I like your the way you're saying the PTFE has to wrap everywhere around the tooth. It makes a nice even layer, because previously I think the mistake I might have made is allowing the PTFE to bunch up, and then that may distort the way the matrix actually sits, and they might actually like open it up and then create more mess.
Correct. And also, I mean, it has to be very thin. So to be perfectly honest, sometimes I like to use the yellow stuff, but the yellow PTFE, but actually it's really the white one. Another thing you can do is just to secure your PTFE very nice so it doesn't end up in your assistant suction, is that you take the two tails at the back and you twirl them together. So that also then tightens the PTFE, and then you just cut it. So that way you can actually, etch it, rinse it, bond it, air dry it, and nothing flies off, which is just wonderful.
The sound it makes with the suction it scares everyone. Scares all of us. I think everyone knows what we're talking about. That's the worst bit.
It's terrible. It's absolutely terrible. So yeah, I totally agree with you.
So you've discussed these points in terms of reducing the mess. Everything makes sense to me so far. Then you remove that last bit of PTFE, and then you're using the seri strip, the seri saw even, metal matrices to clean in between. Any tips in doing the interproximal cleaning without accidentally creating like a diastema or too much space? Hello, YouTube Protruserati. I know you're watching on YouTube, and I hope you're enjoying this episode so far. But I wanted to highlight, in case you don't know yet, we have an amazing viewing experience on protrusive.app, our website, our network, our platform. So I just want to spend a minute to show you what this looks like. On the left side, you see the navigation, and when you join the app, you get a 1-minute video tour of the entire network. Now, in terms of where the magic happens, that's in the Protrusive community, because you might come for the content, but you'll stay for the community of the nicest and geekiest dentists in the world. We have all these polls, we have a chat group, there's always active chats and dentists helping dentists. And really what I want to do is create a really supportive environment that's not like the environment we have on Facebook, and it's built on the values of niceness and geekiness. If you are nice and geeky, you belong here. Now, to make this a safe space, we have a manual process of approval. We actually verify that you are a dental professional before you get in here. So we have hundreds of applicants a day. So if it's been about 2 days and you haven't heard anything, either something's in your junk or you need to reach out. If you're still waiting to join your tribe, email marie@protrusive.co.uk. That's MARI@protrusive.co.uk, and she'll investigate what's happened. Now, all the videos you have on YouTube are also on here, but you actually have some extra ones for free that you don't have on YouTube. So you get some bonus content that's not on YouTube. And actually for the future, I'm not taking things out of YouTube, but some things are not appropriate for the wider public, and I want to sort of safeguard that information, which is like dentist talk, if you like. So that's why a lot of the content is only here and not on YouTube. So you're kind of missing out if you're not on here. That's why I'd love for you to join there. And if you join one of our paid plans, then what you get is access to the CE quiz, like this one, and you can get CPD or CE certificates, and also you get our premium notes. So these are a great aid memoir or revision for an episode to really cement your learning. And whilst we have ads and YouTube places ads on YouTube, we don't have that on our network. So for the paid plan, you get to see all of the premium notes without any of the ads. And of course, you get to support Team Protrusive and help us to continue what we're doing. I'm just going to gloss over the Protrusive Vault, which has all our infographics and downloadables. These are all our masterclasses at this moment in time, and we're always planning to add more. And if you look at them, there's about 1, 2, 3, it's about 7 of them. But actually, if you look at the replay section, some of the live masterclasses that I've done and some of the training that people pay for on other websites is all on there, included as part of the masterclass subscription. And if you're a student, don't fear, we have a special section for you with all the student notes, which anyone can access. So for example, here is one on exodontia. So it's all there waiting for you on Protrusive guidance. Please head over to the website, which is protrusive.app. Make an account on your browser. This could be Safari, Chrome, however you want to do it. And once you've made your login, then you can download the iOS or Android app and then log in through there. So the reason to make the subscription primarily on the website first is that you get access to a free trial, which you don't get if you do make an account on Android, iOS. If you make it on the website, you get access to the free trial, and you get our best price if you sign up through protrusive.app. So our best deals and free trials are only on protrusive.app. Of course, we always put the link below in the description, and thank you so much for enjoying our videos on YouTube. But it's now finally time to level up your experience. Back to the episode.
Hasn't happened to me yet. You just
This is a question from the community, actually. So I thought I'd pass it to you.
You just have to be careful. And there's also, again, you don't want to open up the contact points. How you hold your polishing strip is very important. So what people tend to do, and this is actually, I learned that from Newton Fall ages ago, what people tend to do is that they wrap the polishing strip around the tooth and then start cleaning
Like a C,
like
like
that.
a wrap it around a C.
Correct. What you should be doing is feeding it on one side. Say you wrap it around the buckle of the one tooth, but around the lingual of the other tooth, because that
S
way
shape.
you're not going
That makes an S shape. So C shape.
Yes,
Yeah,
exactly.
that's
Oh,
it.
you're so good. You're so good. Exactly. You do it as an S shape. That way, you're not going to open up your contact. Another thing is, ideally, the contact should actually not be part of your design anyway. Even in cases of color change, the lab says stop 0.5 short of the contact point. Do not wrap the design into the gingival embrasure. And if you have, excess below the contact point, which for some reason you haven't, there is just too much, and then you can actually use, this is why I like the metal strips, because you actually can cut them in half and make them much thinner. So then you can just feed them in below the contact point and just polish below the contact point. I found that to work as well.
When I've ordered these metal strips, then when you order in bulk, you can actually ask the manufacturer to cut them in half height-wise, and then that's a real top tip there. Just makes it a bit fiddly, but once you get it in the area, in that sort of embrasure area, it's so much easier to handle. So I'm glad you mentioned that. So it's a top tip there. And then when you actually come to that stage, now with the techniques you've given there in terms of good stent design, good design to begin with, careful use of PTFE that's judicious. Once you get to that point, there's still a bit of cleanup to do. What instruments or techniques you advise from there that should be in our armamentarium?
Okay, 12 blades, tons of 12 blades, have more 12 blades available than you ever think you need, because what you want is, so I have typically always 3 handles going. So that I just, new one, because as soon as you start cleaning up, there's already start to blunt, and then you're starting to have a problem. Okay.
I love this because what you don't want to do is what I've done is you keep wasting time taking the actual blade part off and putting a new one on. If you have 3 handles ready with 3 fresh blades, it just makes it so much quicker and less stressful in that clean phase.
Correct. I'm so annoyed if I have to wait for anything. Generally, I'm really a bitch to work for, So my girls know that I will get absolutely incensed if I have to wait for something that should be there. All right. So I've been a dentist for 33 years. I haven't got any more patience. I don't know what to tell you, So one of my favorites is, and you get that a lot, particularly when you get the PTFE and you do the little wrap around and back, and then you wanna cut the tail of it. And you always get that scissor that doesn't cut. Do you get that one too?
Dude, that happens everywhere.
Or if you cut retraction cords and you want to cut a retraction cord and you just have it so beautiful, and then you cut it, it doesn't cut, and then you rip the whole cord out again because they give you a scissor that doesn't cut, and I will go absolutely berserk. To that extent, we have Lachal scissors in our practice that are only there for cutting cord. And if I see them cut anything else with this, all hell will break loose.
That's a big no-no.
No.
Excellent. I love that. You really related to every single dentist ever. So
oh my God.
Really, multiple 12 blades. What else?
Multiple 12 blades, and do not start using the seri saw before your interproximal is already clean. Okay, the seri saw is just to get rid of that last bit of stickiness at the very end. In the first round, you can use it pretty much at the beginning. Another thing people do with the seri saws, which I've seen in my courses a lot, they don't get that it's not an instrument to praise teeth apart. You have to use the saw at an angle to let the saw blades engaged with whatever resin is in the interproximal. So what they try and do, they just press it in, and what it will do, it bends, and then you need a new saw blade. What you have to do is to introduce it into the interproximal in an angle and start sawing with it, because it's a saw. Okay, so that's quite important, I found.
Can you explain that to me a little bit more in the sense of something I've been guilty of this when I've done my second stent, and sometimes the first thing I reach for is the saw just to break up any excess resin. But what should you use before the seri saw?
Particularly when it comes to the second stent, always use the blades first. Also, to get your Teflon kind of unburied in little bits. Okay. Once you've used the blades a lot, then you can use the saw.
Okay, got it.
And one thing with the Teflon, I just wanted to say, this is a trick, and you won't believe how long it took me to actually figure this out for myself. Teflon absolutely hates dry. Okay, so when you cut a piece of Teflon and everything is dry and you have a dry glove and you want to get it, and it sort of starts flying and starts sticking to your glove, because it has a little electric charge. So what I do, as soon as I work with Teflon, I put my gloves in a little bit of water and just wet them a little bit, and that way the Teflon will behave. Also, if you have to manipulate the Teflon on the tooth, a slightly wet brush is going to be your friend. That's a big thing. And what you mentioned before, which is actually super important, is that you don't want the Teflon to bunch interproximally. So because that is also a problem. So after you've wrapped it around, as I say, stretch it around the tooth, introduce it into the second contact, and try and pull it through. What you then have to do is that you take a fine instrument, like for example an IPC, and you adapt it a little bit in the interproximal so it doesn't
It's
bunch
like inverting
there.
rubber dam, right? It's like you're like
Yes,
inverting.
a little bit. You want it. That's what you want to do.
Do you ever use PTFE like retraction cord, and have you ever found the
Oh,
need
I
to
love
put it
it.
in the gingiva?
I love this. I so love it. It's like the best, particularly if I have to do cervical fillings.
Yeah, same.
It's my preferred way. I mean, what I do first, and I also do it, I mean, I'd like to say that I do everything under rubber dam, and I do many, many things under rubber dam, but there will be the odd crown that is so subgingival that you cannot get the rubber dam on. I mean, Celine Heighton, I am not. David Gerdol, I'm also not. I'm just, a little dentist in Hong Kong, but I try my best. Now, I always felt very bad about this, that why can't you always get the rubber dam on? But as I said, it happens to me on occasion. So what I will do then is that I actually pack classic retraction cord first and then roll the PTFT and put that on top. And that works incredibly well. So I have no moisture and have sufficient retraction. And I have, composite that doesn't stick, or cement that doesn't stick to my retraction cord, because that's a pain as well.
But do you ever use it, again, a big fan of PTFE in that way, but do you ever use it, from what you've shown me, it doesn't look like you use it for your injection molding cases in the gingival sulcus?
No, I wouldn't. And this is why I would say, if you can, and you know what, I haven't done this yet, and I was thinking the other day that I might actually start doing that. Okay. But typically, I mean, my stuff is finished slightly short of the margin anyway. And one of my biggest frustrations with injection molding is that, because I have not been able to use a full rubber dam on the, like the best I can do so far is a split dam. And I'm really working on that, because I want this to, look good for a long time. But what you will see on many cases is that you start to see margin discoloration on the buccal after, say, 2 years, or a little bit longer. You get more and more discoloration on these margins, and I presume that is because you don't have proper isolation there. So I might actually try and do Teflon in these areas and see how I do. But the issue is obviously, of course, that unless your patient has excellent oral hygiene beforehand, if you pack cord in these cases and then Teflon on top, it might actually start to bleed really a lot. Hence, another thing that is unbelievably important, I feel, even more important than in other cases, is that your patient has absolutely incredible oral hygiene. before you start these kind of procedures. So this is, always a case where, we do the good old urine slots, the diluted household bleach. I'm sure most people know about this, but do you want me to go into that a
No,
little
please.
bit?
I don't do this, so I would love to learn more. Yeah.
Okay, so I hate chlorhexidine. Okay, so in my practice, there's no more chlorhexidine because it's actually a really shitty rinse. For number one, it's not even good as a mouthwash because it just inhibits some bacteria and not others, and then you have competitive inhibition issues. It stains, it causes altered taste sensation, it messes around with, your bioflora, causes shifts of nitric acid, with breathing issues, raises blood pressure. And in the States, there actually have been cases of anaphylaxis. I think a couple of people have died from it. So no more chlorhexidine. Plus, it actually doesn't work. So what we do know works, and this is, on the basis of the research of this periodontist called urine slots, is two things really work. One is povidone-iodine. Okay, that really works for tissue and bacterial control. But the problem with it, it's red, it tastes yucky. And the other thing that works is just diluted natrium hypochlorite, and that's just basically off-the-shelf Clorox, that you dilute. So what you typically want is, the 5% you get in the supermarket. I don't know what it is in the UK, but you want it to be unperfumed. And I put that in little dropper bottles for my patients that you can just buy off Taobao or Amazon. You can buy 50, they cost next to nothing. And then I ask them to put one dropper in 50 milliliters of water. I give them a large.
So literally one drop is it's half a teaspoon.
Half a teaspoon. It's like you want to have I think it's a 0.025 dilution. So what it will taste like is like a really yucky swimming pool. So you can figure it out. So it needs to definitely taste like swimming pool and a little bit heavier than swimming pool even. But so it's, you can put peppermint oil in to improve the taste, but that hasn't really, made any difference. And what I like to do is that I give them this large 30 ml syringe and a large blunt needle tip. So pronto, they're having like a DIY irrigation device. And what I tell them is you do this now twice a day. You floss first, then you draw up this fresh solution. You have to make it fresh every time they use it. And then you squirt this in between all your teeth, okay? Because we want the biofilm to be, because even if you can't remove the biofilm 100%, this will actually sterilize it. So if they do that for 2 weeks, they'll have to brush afterwards to get rid with, the swimming pool taste in their mouth. So I tell them, brush after the irrigation and then also brush your tongue. So, your mouth will taste nice. They do this for 2 weeks. Typically, they have fantastic tissue. It's a great way to do anything restoratively, I find. So, yeah.
I mean, that will help in the mess in another sense in terms of bleeding and that kind of mess,
Correct.
the red mess. We talked about the white mess. We got to talk about the red mess. So I'm glad you mentioned that as a Brucey bonus as well. Amazing. We've covered a lot of ground there, Sandra, in terms of cleaning up mess. I feel like to summarize the principles is all about design and being meticulous with your design and being very purposeful with the technician and guiding them to make sure they create those areas where they do not extend the digital wax into. The every other tooth model. The only thing worth maybe touching on that we talked about the 12 blade and stuff, but the only thing that perhaps we should just finish on is you mentioned the importance of the pressure pot, but like you said that for a full mouth rehab case, like the kind of one that we're going to do on our course together, the lab should do it, which makes sense, okay?
Absolutely.
But in terms of, do you make stents yourself for the smaller cases, or do you just delegate that to lab?
No. Okay, well, I will make stents for myself if I'm using a heated composite press-on technique, okay? But that's a different, and that I only do for veneering cases, just for anterior veneering cases. Then I make those myself, or if I, because I'm a big fan of, get the shape right first and then do the cutback. So, but this is a completely different topic. But no, I don't do them myself. Okay, I just have found that is just such a pain in the ass. But you can buy one of those aqua thingy pots. They cost next to nothing. Or I don't know what they cost, $400 US. And you can, so it's an aqua press and it's perfect. Okay. The other thing is what I want to say is when you make these matrices, the lab will know that. But sometimes if you were sort of in dire straits and you needed to make one yourself, is that, and this is super important, is that you actually, like with an impression, that you apply the tray, the clear matrix material onto the teeth and into the carrier tray you're using for the matrices as well. Because if you don't do that, you're going to end up with a shitload of bubbles everywhere. So that is very, very important. Maybe we should talk a little bit about the actual tray fabrication.
You mentioned the spacer protocol as well. So maybe let's just wrap up on that.
Yeah, so the spacer protocol is important because, so people say, why don't you just use a tray for this? Because the tray will produce a matrix that is, unevenly thick in different areas, and particularly very thick in the back. So whilst it's okay to use a tray, maybe if you're just doing anterior teeth, it's a real pain if you then end up with a super thick matrix in the back because you won't get your injection molding tips in. So so this is why I asked the lab to create, a so-called putty spacer first, and then use an Essex type kind of material to get them to create themselves a carrier tray, which they then use in order to, make the matrices. And then the whole thing gets transferred in a pressure pot and gets set.
So just to summarize, putty spacer of about maybe 1.5 millimeters spacer. What are we talking? Yeah. And then the Essex is made on top of that. That's now cut away. You can take away the putty now. So now you have a clear Essex. And that Essex is now used on top of the Exoclear in this case to make it, which makes sense. Now, here's an interesting one. How can the lab ensure that they've got, when they're seating the Essex on, that it's evenly spaced? Do you have, like, in dentures, you have like these tissue stops. Do they have like tooth stops?
No, but so we don't want to alienate our people that don't watch the podcast. But what they do is that they're actually because the spacer, the tray they'll be using, the carrier tray is also clear. What they do is that they mark the outline of the teeth and the buccal, cusp tips, so that they know exactly how to reposition the tray. And they've got this down now, so that they don't press it down so too much, so that it doesn't end up too thin. But that is a good trick in the beginning as well, that they that they don't, and they have a little bit of a tissue stop maybe on the buccal as well.
So don't overseat and then underseat to get it about right.
Correct.
To actually make sure the whole putty you made in the first place would make sense.
Yes.
Amazing. Sandra, thank you so much for covering even the matrix fabrication. You've given us good tips to make sure that we're going to be less messy next time we do this. But I think for the full experience, for anyone who's looking to do a full mouth rehab case and wants to actually treat one of Sandra's patients, but in typodont form, and get a coist appliance on yourself, it's a 2-day course we're putting on, led by Sandra. I'll be there to help out. But really excited to learn from you. It'll be in February 2027 in central London. But I'll put all the details so everyone can check it out. But we're looking forward to seeing you again in the UK. And you're so big in Asia and America, and you've done so many in the UK as well. So it'd be great to have you back.
I wish I was so big.
You are, Sandra. Honestly, our community loves you so much. We love your communication style. We love the fact that you're a bit sweary. We actually love that so much. We're very relatable. You're just you wear your heart on your sleeve, and we love that about you.
Oh, that's so sweet. As I say, what I lack in substance, I make up in dirty words. But you have to understand that all these words, because English isn't my mother tongue, so there are certain words that I just throw around, like, the F word, and, not the C word. I don't do that. But the F word, I throw around a lot, because for me, that's just another word, right? Whereas in German, I would probably not say this word. So I would be really looking. I think what we want to say, what we're going to do a lot of the stuff online. But when it comes to the 2 days of the course, I think we can cover so many things. For example, how to do eccentric registration with a coist deprogrammer, when you should use a coist deprogrammer, when you can get away with shim. So we're going to cover all that. I can show you, like, how do I do the lab communication with, like, a very dumb DSD, very few pictures, this kind of stuff. And maybe we have even some time to do some treatment planning together, so it would be nice.
That's why we really are focused on on doing as much of the theory online. So we've got, I think, about 4 hours of theory planned in live webinars, which will be available on demand as well, way before the course. So really hit the ground running so that everyone's course appliance is ready. Everyone can really have a lot of time on the typodonts, actually doing the injection process, supported by GC kindly. So yeah, exciting time. So thanks for coming on again today and sharing all these tips and pearls. Really appreciate it.
Thank you, Jazz. It's always a pleasure talking to you. And you've got, by the way, a huge fan group in my practice. They love you. Oh, Jazz, I love him. I love him. I love his podcast. Yes.
That's very sweet. Amazing.
Right.
Thank you so much, Sandra.
Thank you. Have a great evening, Jazz.
Well, there we have it, guys. Thank you so much for staying all the way to the end. You are a true geek. So if you've already proved that you're geeky, you've stayed to the end. But if you're nice, I also want you to come onto Protrusive Guidance, where you could have got CPD for this episode. For those already on PG, scroll down, answer the quiz, claim your well-earned CPD certificate. We are a PACE-approved educational provider, so your CE credits are valid worldwide. If you'd like to access all our infographics, all our podcast summaries and transcripts, and all our masterclasses, head over to protrusive.co.uk/ultimate. And of course, if you'd like to join us on this 2-day course, well, it's 2 days of hands-on, and it's 4 hours of live online theory that we're going to do on Protrusive Guidance. So at the time of publishing this episode, all the dates will be there, and if you can't attend 1 or 2 live, it's okay. It goes on demand for you to access lifetime. That's all the prep you need to do for the theory, so that we can actually treat a full arch case of a real patient in typodont form. So you'll do the upper arch one day, you'll do the lower arch the other day, and then you get to equilibrate the occlusion. You'll have a coist appliance fit on you by your buddy. You learn the indications of when you need one, how to use the coist appliance to equilibrate, and how to use shims with it. This is an excellent course for anyone who wants to explore the coist philosophy of occlusion, or really go deep into injection molding, especially for full mouth. So we're talking anteriors and posteriors. There are some nuanced things to consider. This is probably a course that's very difficult to repeat, so it's like a one-off thing this year. The date is 26th and the 27th of February 2027 in central London. The course is held with GC in Milton Keynes. And to learn more, head over to protrusive.co.uk/FMIM. That's full mouth injection molding, so FMIM. The course is limited to just 20 delegates, and it's a very intense hands-on course over 2 days. Check it out, guys. Otherwise, I'll catch you same time, same place next week. Bye for now.